Welcome everybody to today's Daria session. We're lucky enough to be joined by Dr. Suzie Hudson, who's the clinical advisor to the Centre for Alcohol and Other Drugs at the New South Wales Ministry of Health. Suzie is a mental health social worker with over 20 years experience in the AOD sector, mental health and forensic fields, and in Australia and overseas. Susie's worked in all areas of AOD treatment, continues to provide therapy in private practice, and is an adjunct lecturer with NCCRED and NDARC. You've got all your N's covered with the NADA, NCCRED, and NDARC.
All N's, yes.
All the N's covered. So I believe that today, Suzie, you're going to be focusing in particular around case management and care planning and applying the New South Wales Health clinical care standards in the AOD sector. So please,
sure am, Chris.
Take it away.
Thanks so much, Chris. Thanks so much for having me. Hopefully you'll soon see my slides up on your screen. Are they there, Chris?
They are there.
Fabulous.
And I'm blacked out, but I'm still here.
All right, lovely. So thanks so much for that intro, Chris. Indeed, I'm Suzie Hudson with the pronouns she, her, and I am the clinical advisor at the Centre for Alcohol and Other Drugs. I'll show my email at the end of this presentation, so please reach out if you'd like to. And, along the way, please enter any questions into the Q&A box, because I'd really love to hear from you. If I'm saying anything that seems a bit strange, or you want some clarification, or you want to make some input, please do that. Before I get started, I'd like to acknowledge the traditional owners on the lands that we're all meeting today, and to pay my respects to elders past and present. I'm on Gadigal land myself, and I really want to acknowledge the continuing connection that Aboriginal people have to land, skies and waters. And I suppose too, today, particularly focused on case management, you'll understand how a lot of the practices that we talk about are very familiar to Aboriginal and Torres Strait Islander people, and we have much to learn from the way in which they provide their treatment and support to people. And hopefully we can do better to learn more from those healing ways. This is just a little overview of what I'm going to talk about today. I'd also like to acknowledge, while I'm here, the contribution that people with lived and living experience make to shaping treatment, to helping us understand better ways to be inclusive and compassionate in the work that we provide. And so today I'm really going to focus about what case management is, what some of the benefits are to people who may be reaching out for alcohol and other drug treatment. I'll be providing some information on the key principles and practice tips for effective case management in AOD treatment, and then really trying to weave in the New South Wales clinical care standards for alcohol and other drugs, with a particular focus on care planning and case management. And at the end, I'll also provide you with a few resources that might be of use to you. But needless to say, this the clinical care standards is a whole piece of work that New South Wales Health and the team from CCCRED, the COCI team, have been working on to really ensure that there is high quality and safe care being provided to every person in New South Wales. So what is case management? So it's a collaborative and integrated and coordinated approach to the delivery of services and the provision of supportive person-centred care. It really takes a social perspective. And so if you're currently, like me, providing therapy to people as individuals, groups, or perhaps with couples, you know that a lot of the work can be quite focused on the individual sometimes. But what we know is that we're all social beings. And once again, we know that Aboriginal and Torres Strait Islander people have worked and lived in these ways forever. And we're starting to cotton on to the fact of, how important that is, particularly when it comes to the provision of alcohol and other drug treatment. And so the idea of case management beyond therapy is really taking that social perspective view, thinking about a person in their setting, a person and all of the people that might be involved in supporting them, and helping to think about how we support not only them, but their supports. And so in order that we can increase their functioning and the wellbeing in the community. So case management in alcohol and other drug treatment is a real opportunity. And that's because many of the people who come to see us have experienced both trauma in their lives, but also that very strong experience of stigma and discrimination for the mere fact that they may use alcohol and other drugs. Certainly in our healthcare system, we have a lot of work to do to really break down that stigma and discrimination. And so case management actually provides a real strong opportunity for all of us to act as advocates and navigators to the general health, welfare, and social services systems. And that means that we really are always thinking about the person in their context, in their environment. And really, if we fail to address these co-occurring needs that people naturally attend our services with, whether it might be physical health needs, emotional or psychological health needs, we really miss out on an opportunity. So we know that if we fail to address those co-occurring needs, it could indeed exacerbate the person's experience and indeed result in treatment dropout. And the reality is that we as people who work in alcohol and other drug in that specialist field, we can be that conduit to better care. We can help build those bridges to ensure that all of our people who access and engage with us get the services that they so truly deserve. This is a bit of an idea of the key principles of case management, and some of this I've taken from what the literature tells us. There's a long history in disciplines such as social work, for example, of which I am a part. I'm slightly biased there, that really ensures that we're thinking about the whole person, providing that holistic care. This dovetails nicely with the clinical care standards in New South Wales for alcohol and other drug treatment around being really person-centred, client-led and collaborative. That means that the person who's accessing treatment is indeed the expert in their situation, and we need to be really led by them about what it is that they would like to get out of coming into treatment. What are their goals? And to shape, review, monitor, to really shape that treatment as we go throughout that journey. Key principles of case management are also that it's trauma informed, which absolutely fits beautifully with the way in which alcohol and other drug treatment is provided, building on a person's strengths, and very importantly, providing them some choice about the things that they might want to tackle, and certainly also the ways in which they might want to receive that treatment. It also is around reducing service fragmentation. We know that a lot of our services, both health and welfare and social services, are really siloed, and we do our very best to try to break down those silos. But what case management provides is an opportunity to really use our partnerships and use our links to serve as a navigator and orienter of the service system. It's also being really mindful around culture, being culturally sensitive and inclusive of all people, really knowing that they are the experts on their lives, but perhaps, through time or circumstance, they may well have been disconnected from the very things that can be the antidote to some of the issues they've been experiencing with their substance use. And so we might not be able to be the experts, and certainly as a non-Aboriginal and Torres Strait Islander person myself, I would never profess to know or to be able to link people in or to do particular work around Aboriginal culture, but I may be able to provide a bit of a link to those specialist services, that cultural knowing, and to elevate that Aboriginal voice in terms of healing practices. The other key principle of case management is it's anticipatory and it's flexible, which means that whatever plan we may have today might not be the plan we need to make tomorrow. And again, that's where those clinical care standards come in nicely, because it really puts an emphasis on monitoring and review at regular time points. So holistic care really tells us what underpins the idea of case management, that we're thinking about the whole person. A person may present to our services absolutely with concerns, or other people are concerned about their alcohol and other drug use. But in fact, we often know that that's a symptom of other issues that might be going on. It might be a co-occurring physical health condition or a mental health condition. And the use of alcohol and other drugs may actually be one of their strategies that they utilise to manage or to distance themselves from some of the pain they may be experiencing from either physical or mental health needs. We also know that many people that may be coming into our services may have connections with child protection services or criminal justice services. And so the onus is on us to really ensure that we're able to help them to navigate those various responsibilities they may have, and to provide opportunities where they can grow and strengthen some of the personal skills they have to increase their own well-being and that of perhaps children in their care, and or to be diverted or avoid the criminal justice system altogether. Similarly, there may be specific special housing, welfare or social needs that need to be addressed, and perhaps because or as a result of alcohol and other drug use and the stigma that people face, they've not been able to get the services or access to the services they need. And that's where good, strong case management can come in. I like to sort of think about case management in terms of these 3 Ps, if you like. It's good to have a few little tools up your sleeve that make things a little easier for you. And so the first P I like to identify is priorities. So when people are engaging in alcohol and other drug treatment, there's a need to address a variety of needs in a holistic way, but what are their priorities? What are the things that they are most needing right now? And perhaps someone might come to you concerned about their alcohol use, but in fact, the real issue is they have nowhere to stay. They've got no roof over their head. And so addressing alcohol use, whilst, may well be one of the key things that they would like to do, we know that if we don't address some of those very basic needs, it will be very difficult for any treatment gains to be sustained. The second P is partnerships, and that's really around our responsibility as workers in the AOD field to forge links with relevant community partners. We can't know everything about everything, and so it really serves us well to get in early and spend time developing those partnerships. Now, I know as well as you that a lot of the time we're not particularly well funded for those additional pieces of work that we do engage in. A lot of the funding that we get, or certainly the key performance indicators, are oriented around direct client contact. But we know that in order to provide that holistic care and do case management well, it's about forging those relationships in the community with other service providers, whether that might be domestic and family violence services, having a cup of tea with the child protection services, so that you're ready and prepared should a client or a person reach out for AOD treatment and need to have those links to support them in their journey. And then the third P is around planning. And so that's really engaging in this collaborative process about how best to coordinate the care that's being provided. And traditionally, we've often done a lot of this planning outside, or at least we gather information from a person, and we'll go through that soon, in terms of thinking about our clinical care standards processes. But we don't always think about how we might plan alongside the person that we're there to serve. And I'd really encourage you throughout this presentation to think about how we might better collaborate with the people that we're there to provide treatment to. I want to present this little case study to you just a bit as an illustration of some of the things that I'm talking about there. And it's about Kyle, who's a 27-year-old person who identifies their pronouns as she, they. At assessment, they describe concern about regular methamphetamine use. They also like using GHB, MDMA, and drink occasionally. They report that anxiety has been a long-term concern and that sleep is sometimes difficult. So while care has been provided by a psychiatrist in the past, it was through a youth program, and care needs to be transferred. Kyle is currently staying at a friend's house. It's short term, and the relationship is complicated as they have engaged in casual sex from time to time. There's a history of family trauma that Kyle's not comfortable to discuss right now. However, they have previously been in out-of-home care. I'm sure you'll agree that scenarios such as Kyle's are relatively common for us in AOD treatment, and that there can be lots of different things that a person may present with. Once again, though, the emphasis is on what is it that Kyle feels are the key things that they would like to address? What is it that they found difficult over time? What supports might we put in place that can actually bolster the treatment outcomes they might want to attain through alcohol and other drug treatment? So how might we respond? If we're thinking about good case management, my role, perhaps in a service, perhaps is to provide, say, therapeutic counselling, for example. So whilst my sort of focus is going to be very much around those AOD goals, emotion regulation, the trauma that Kyle has experienced, any other types of needs that really respond to the emotional, psychological needs, it's totally within my remit to think about good case management. And that will have to involve a number of other services if indeed Kyle is happy for them to be involved. With regard to the psychiatric side of things, we know that unfortunately those who may have created a connection with a psychiatrist as a young person, these connections may have to be transferred in terms of care. So we're really looking at what psychiatric and mental health supports might be provided. We're also going to think about that housing situation and teasing out the elements of that. While there's obviously a connection there with a friend, it appears on the face value that this is not exactly the best or most supportive way of living for Kyle. And we also got a little bit of a hint there about some complexity around the relationship itself. And so do we need to explore perhaps some specialist domestic and family violence support? And so what that's telling us is we don't need to be experts in everything, but we certainly have a responsibility to explore and ask about all of these elements and to have decent, well-structured connections with other specialist services to support. We also often know that people may have cultural identity that's not been fully explored or realised. And these are also about looking at what the strengths are going to be. And good case management really looks at not just the things that might need to be addressed or supported, but very much thinking about what are the ways in which we might be able to link up that person so that they can get the support they need and ensure that they're actually going to be able to sustain any goals that might have achieved around their alcohol and other drug use. So we're really thinking all the time about that whole person. And so you can start to see some of the differences about what you might be doing in terms of providing therapeutic counselling. And then that other side of things, which is that case management, which is around bringing together and coordinating that care as much as possible. We also have to be really mindful of confidentiality within the bounds of case management, particularly if we're going to be working with other services. And that shouldn't get in the way of really comprehensive, seamless care. What we don't want to have happen is for someone like Kyle to have to retell their story over and over again, re-traumatizing themselves and not necessarily getting the things that they need. And so it's around really being clear with other service providers what the lines of clinical governance are, what the roles and responsibilities might be, and certainly that we're raising very early with Kyle about the benefits of understanding signed consent. So that is to say, we raise it early with someone like Kyle, we explore with them who might be useful to share information with. You know, are there certain people, for example, a new psychiatrist, where we can ensure that good handover has happened. We could perhaps be involved in a warm referral where they're having the psychiatrist that Kyle was originally with, then with the new psychiatrist, and we're involved as well, so that there's some consistency of messaging as well. And so it's really about clearly outlining what information, so how information will be shared and why that might be. As therapists, as counsellors and nurses, people in the medical field, we can get quite sensitive about confidentiality and privacy. And whilst that is absolutely essential for trust and is legislated and very clear in our policies, it's also about saying with good coordination and good case management, we can actually clearly articulate where it's appropriate for information to be shared, including the person or the client that's involved in our service in that process of sharing information, so that they bear witness to that experience as well. It also tells us that within good case management is that need for good case coordination and review meetings. And that's what I alluded to before, is that whatever goals Kyle is setting or we're setting alongside them, we're really thinking very clearly around being able to review those. We've got regular time points where there's a review process occurring, and we can adapt and shift the therapy and the case management to suit that person. And that's why it's so important to continually be getting feedback from Kyle about how they are experiencing the treatment we're providing and the case management with the other services that might be involved. So you can have two different types of approaches, broadly speaking. I mean, there's lots of different literature that talks about different elements of case management, whether that might be about specifically around brokerage, for example. So that's the provision of funds to support other types of services, or supporting transportation, for example. But usually they fall into two broad categories, and that's around a primary case management model, which is where we're talking within a service or a single organisation. There's one primary case manager or coordinator, and that they sort of take responsibility alongside the person that they're there to provide support to. And it's through them that the services are brokered, if you like, or involved, but ordinarily it's happening within one organisation. So it might be, in the case of, say, St Vincent's Hospital, it might be that you're the case manager, but there's certainly, it could be anything from wound care. You're helping to coordinate and ensure that person gets that support. It may also be around, other physical health conditions with a doctor, etc. And then there's shared case management, and that's where you've got a much more interagency or multiple service situation, where there might be a team indeed that shares the responsibility and makes coordinated decisions in collaboration with the person. An example of that might be there's a group. I know that Haymarket Foundation are linked with ADAPTS and the HARP units around coordinated care for people who may be using alcohol and other drugs and may be HIV positive. And so in that shared case management model, you're having particular services who are specialists in a particular area, all coming together to discuss cases and where appropriate to involve, obviously, the person themselves to ensure that they're getting all their specialist needs met and it's being done in a coordinated fashion. So I want to switch now a little bit into how these principles and approaches of case management, which is that very social oriented focus of caring for or supporting someone, and weave that in with the clinical care standards. And so these were produced and certainly spearheaded by the Koki group, which are out of CESLID, led by people like Nick Linzeris and Christy Mammon and Annie Malcolm. And I'm sure you've come across them in your travels in terms of great education around clinical care standards. Tanina Harvey was involved in that work, and many others. But the great thing about it is it's starting to say that every person that reaches out for alcohol and other drug treatment support has a particular standard of care, and that each of them receives each particular process and it's underpinned by very specific principles of person-centered care, of trauma-informed practices, and really ensuring that it's coordinated. And so it really helps to know what a person can expect from their care. It provides that guidance to clinicians and staff, and really, I suppose, sets out a very clear process for ensuring that people's care is really tailored, responsive, and can be monitored and evaluated. So you're probably familiar with this, hopefully, as you've gone along, and I'd encourage you to check out the clinical care standards for AOD treatment. You can find them on the New South Wales Health website. There's also a module that's about to go live via HETI and be made available to the NGO services as well, which is great news. So these largely outlines these processes of care. And it really starts to break down some elements that happen for every person who's reaching out for alcohol and other drug care. And it will come no surprise to you that all of these elements, intake, assessment, care planning, risk identification, response and monitoring, ongoing monitoring and review, and transfer of care, don't always happen in a linear fashion. You know, where we're constantly checking in with our with clients, with people who are accessing treatment, and just checking out how they're experiencing that treatment and whether there are things that we might need to change. It talks to the importance of creating safe environments, to finding out all the information and being very inclusive of that, and the very important part of case formulating and care planning alongside the person that we're supporting. So how do they make a difference? Well, it's really about setting out very clear guidance about ensuring there's access, engagement, and those underpinning parts of harm minimisation, that every person seeking out treatment from across New South Wales gets and receives the highest quality care. It really is also about ensuring that clients are at the centre, and there are very clear parts of the standards that really talk to clinicians and what their responsibilities are, and those of health services, really ensuring that there's high quality recruited staff, there's that training and supervision, and certainly the clinical care standards can be used very much in that supervision space. So I'll take you through very briefly some of these elements of the clinical care standards. You may well be familiar with them already, but I will take a little moment to speak specifically around that care planning, because it does weave in quite nicely with this idea of case management. So that intake process is really, one where, it's at the very start of the process, and it's so important. We don't often give it the credit, the emphasis that it deserves, but we certainly know how important it is when someone's reaching out for the first time to enable a safe, supportive environment where they feel heard and listened to. And so we're trying to, at that point, really thinking about what are some of the key needs. In the case of case management, we know that intake may already be flagging with us some of those organisations that we might need to strengthen partnership with, or indeed to get them ready to potentially be able to work with us, alongside us, in the care of the person that's coming to see us. We also, though, know that intake interview is not equivalent to a comprehensive assessment, because that's what will come next, obviously. In that comprehensive assessment, that really provides fertile ground for finding out all the information about what people want and need, absolutely elevating the strengths that they already possess and how we might grow those strengths. Sometimes we can get very problem oriented, and case management is really about looking at the whole person and all of their strengths and resources as well. What are we going to do to grow those? And so comprehensive assessment helps us pick up some of those. It will inform the case formulation, and it will certainly look at the, very crucial to the care plan we're going to provide. Care planning comes next in terms of how the standards are laid out in the clinical care standards document. But of course, we know that some of the other elements that we'll touch on in a moment, like the risk monitoring and the outcomes monitoring, are all part and parcel of these early phases of, and then reviewed and revisited throughout the client journey. I want to just pause briefly on care planning. Obviously, care planning really is a collaborative experience, sitting down, feeding back to the person we're working alongside. Have we heard what their needs are appropriately? We're really thinking about designing and documenting goals together. What are the priorities that they have for their treatment? And really being able to share that care plan with them. And I suppose too, as we mentioned earlier, having really explored confidentiality, we're really clear about that, and we can get their consent for any information we might share as part of a case management process. It's really, I suppose, important that we are always thinking about, in this care planning phase, what other specialist services might it be worth involving very early on, and being able to have shared care plans that then ensure there's consistency of approach. And it might also need to include other supports and networks that they have. It might be family, it might be a significant other or friends, or it might be community members that perhaps they had in their lives previously that we want to bring back into the fold and to really start to be part of the team that serves a person. The thing about case management is it really starts to challenge our way of thinking about that very individualistic way or a very individualistic approach, and says we actually need a team. You know, every person needs a bit of a team around them, and it's our job as case managers to really be able to pull that team together in a nice, cohesive fashion. Of course, we'll be identifying and responding to risk issues. They can be identified as either core or non-core risks, and these are presented to you here. Very early on, as part of that screening and assessment, we'll be asking about suicidal ideation. We'll be asking about potential domestic and family violence risk or other harm, and being very keenly focused on, you know, what are the things that we're going to need to put in place to ensure that person is as safe as possible. And that's where good case management principles come in again, with we can't be with that person at all times, so who else is going to be part of that team with us alongside the person and supporting their treatment goals. Monitoring treatment progress and outcomes is an ongoing process, and setting clear timeframes throughout the treatment journey is really important. And I suppose really getting feedback from the person you're working alongside, not just in terms of some of the measures you may use around mental health or general health and well-being, but also about their experience of what you're delivering. Do they feel safe? Do they feel heard? Are the relationships and partnerships that maybe you're fostering through the case management process, are they serving the person in the way that was intended? You know, if indeed over time, you know, outcomes, you know, and the person themselves is expressing concerns around whether it's a good fit for them, it's also about trying to provide choice. And that's central to trauma-informed practice, is people being empowered from the very beginning involvement with us, that they feel able to tell us when things are not as they would like them, that they're right for them. And that you can absolutely set that up very, very early. And that happens through this outcome monitoring process, which is to say, you're telling that person, I'm going to ask you regularly about how treatment's going for you, how you feel like I'm serving you in the context of this treatment, and what could I be doing better. It's really useful to set that dynamic and that relationship up early as part of that therapeutic alliance, so that people feel able to share those concerns, to say, well, look, I don't know that you did really hear what I had to say, because my priority is more about, you know, gaining some better access to my children, for example, and you seem to be focusing more on this aspect. And that gives us a real opportunity to be a partner with the people that we serve, rather than leading the therapeutic or the treatment into places that we deem important. And so monitoring progress and outcomes and getting feedback about experience is essential throughout this process, and really reinforces good case management processes. Transfer of care, of course, very important, particularly when we're thinking about different stages of the treatment journey. And that involves really important and strong documentation. Now, in the case of, you know, in case management situation, it may well be that the transfer of care means that the whole case is moving to a different area or a different treatment place. And so we need to be mindful of that too. But certainly in other cases, depending on where a person might be in their treatment journey, we might be able to still provide that overall coordination as part of case management to really ensure there's that consistency and that person isn't sort of falling through the gaps. And that's where transfer of care has become a particular area of focus for us in alcohol and other drug treatment, because we know that people can regularly be lost to treatment. They perhaps finish a one particular part of treatment, and then we're not sure where they went, because that transfer hasn't happened appropriately. So it's a really important one to keep our focus on, and something that case management can really assist us with. You know, it really supports us in that way. There are lots of supports in place, particularly around the clinical care standards. We know that within the standards themselves, there are some really great templates. So there's some checklists that help an organisation or a service prepare for implementation of the clinical care standards. There are some really great tools that you can use to really ensure that they're being applied in the right way. There are also lots of other types of supports that are on the way, including workforce development tools that are sort of include learning pathways, competency assessments, and some audits to track progress, so that organisations, managers, and workers can all be involved in that process. You know, in terms of the clinical care standards, it really points us in the right direction in terms of our principles, what are our key principles, and bringing it back to case management really places an emphasis at the person being at the centre. And so that brings me neatly back to Kyle. So we really want to ensure that these things are coming together. So Kyle is at the centre of their treatment. There's collaboration on goals. They're developing a care plan that identifies who to involve and how to involve them. And that care plan and the case management planning and the goals for treatment or support are prioritised by them, by Kyle. So, for example, we're really wanting to ensure at all times that we're checking in, that we are ensuring that Kyle is aware of who is involved as part of that case management and what roles that Kyle themselves would like those people to play. And then what's my job? Well, my job as the case manager is to play the roles of advocate, firmly and strongly. That's around Kyle's rights for high quality care, provided in the way that suits them. Advocacy can be a tricky part of our work, but in case management, it's central because it's really about indicating to service systems what is it that what are their responsibilities? What is it that we can help facilitate access to? And for clients of alcohol and other drug services or people who are engaging in drug and alcohol service provision, for a long time, it may well have been very difficult for them to gain access to the services they need. Indeed, we know, particularly around housing support, it can be a real barrier for people, you know, getting the roof over their head that is required, and that will ultimately support them in any changes they would like to make in relation to their alcohol and other drug use. And so advocacy is really key and very central to case management. My role is also as navigator. So I'm there to understand, having laid those foundations, and I'd really strongly encourage everybody listening today, if you're a manager, it's about ensuring that your staff have time as part of their work role to engage with other services. And when I mean engage, I mean actually go and be there with those services, see what they do, how do they work, have a cup of tea with them so that you're able to get on the phone to them if you need particular support and to have them involved in this case management process. It really breaks down and avoids that crisis, lurching from crisis to crisis. So those strong relationships are really, really important. And that's that whole facilitation side of things. It's the warm introductions, it's the meetups, it's the case conferences that are part of case management that really can respond to the person you're working alongside's needs. You know, have there been relationships that have broken down with certain services? Is there something that you can do back up into that advocacy role to help them get their needs met? And then really my other role is around coordinator. And that's the beauty of case management, is that it serves as the antidote to the siloing of service provision. It puts that person at the centre and wraps the services around them in the way that, you know, it acknowledges the power that we have as service providers to pull those levers to ensure people get what they need. It's also about empowering that person, Kyle, to make connections in ways that they are getting their needs met and their voice is truly heard. And so together, these elements pulling together in sort of summary, it's around ensuring that you're able to engage in those different processes outlined in the clinical care standards, that you're adhering to some of the principles around good care, which is around being trauma informed, elevating the Aboriginal and Torres Strait Islander voice and knowledge around healing. It's about real acknowledgement of diversity and the strength in diversity, whether it be sexuality and gender diversity, whether it be cultural or different heritage diversity, and encouraging that, and using these as the strengths in which to provide support to people. And the clinical care standards take you through those processes and mirror nicely what's important about case management, which is really playing those roles outside of that very individualistically focused therapeutic or counselling role that sometimes we might find ourselves in. We're really always trying to push for that holistic care. And that's really where good case management comes in. And so now really it's about saying, I hope to be able to hear from you. Have you got questions, queries? Have you got examples perhaps that you've engaged with in your time at work? Now's the time. I'd really love to hear from you. I'll end the slideshow now, but other resources you can find absolutely on the New South Wales Health website. There's the COKI website you can have a look at, and there are some HETI modules as well. So I will just stop sharing my screen. I can. Has that stopped sharing, Chris?
It sure has, Suzie, and thank you very much for that very thorough and entertaining presentation. So please, firstly, I encourage everybody to as Suzie has said, please, even if it's not even a question, it's more a comment about experiences that you've had or anything like that. Please post questions in the chat, and I'm sure Suzie would be more than happy to hear your feedback and answer your questions as they come up. I was going to say, I thought it was interesting you were talking about having that time to go and meet with which I can already hear people sort of saying are you
joking, Suzie?
Yeah. But look, I think I obviously I'm more medical in my in what I do, but I think I do think about I feel like some days I need to go and spend a day down at the various rehabs across Sydney to sort of see what their models are like, and almost spend the night to really
amazing.
Get that. Yeah, I mean, you want to know what are the services you think work well and why they work well, and the personalities they fit. And there's sometimes it can just come down to what's available, which is less than
True.
ideal. But yeah, I thought that was a very valid point.
Yeah, Chris, look, I think it is very difficult to juggle the need. We know there's unmet need for people reaching out for alcohol and other drug treatment. We know that. However, as someone who's worked for quite a while in this space, I would strongly encourage people to rethink how they do their workload. Sometimes it may well be advantageous to use some portion of your day or your week, 2 hours out of your week, to actually go to some of these other services, to actually sit down, particularly when we're talking about challenging areas like child protection, sitting down with your local child protection workers, getting a common language, understanding how to work better together means that when the person comes along accessing treatment, if we can actually work better with other services, then we're more likely to actually get the outcomes for that person that they are seeking. And so you have to sort of think about, yes, you could see another person, another client and another one and another one. But if you don't have any of those mechanisms to properly case manage, what is often a person who has multiple needs and needs the input of multiple services, if we can't do that properly, we often lose those people anyway. So I'd really encourage where we can that we foster those relationships. Yeah.
No, it's interesting that you touch on child protection, and that and I don't want to throw any child protection service under the bus or anything like that, but we certainly did recently have a bad outcome. I don't think there's another way to put it. Sort of a negative outcome for somebody who was involved with child protection, and I think that was a combination of, yes, background, childhood traumas and so forth. And so, yeah, I think maybe if there'd been a bit more collaboration there, if they knew a bit more about what we were able to provide, and we could maybe guide them a bit more about what other ways we could manage this person. And also they can also maybe, give us some insights into the experiences they have. So, where, sort of, we can sort of understand a bit better the process they go through with their decision making as well.
Totally, because I think sometimes we don't, it's even, establishing some common language and understanding how to communicate together, we can often get that wrong. And I think the person ultimately that bears the brunt of that is the people that we're there to serve. And really a lot of it comes down to that trust, when external services can be invited into our services, and to really get a clear picture of, okay, these people actually know what they're doing. They're taking into account these things. They are thinking about, in this case, perhaps you're talking about, they are thinking about the child. Absolutely. And these are the ways in which we're working for that, towards those goals. I think it just ensures that, again, it's less about us getting our needs met as workers, and really places the emphasis back on how can we work better for the purposes of this person. Yeah.
So yes, please, everybody, if you've got questions, comments, feedback, please share there. I was going to also just pick up on the 3 Ps,
Yes.
which is a nice. Was that your doing, Suzie?
Yes. Well, I like a little. What are they? It's called something, but I can't remember what it is called. But anyway,
it's a TLA. It's a 3-letter acronym. No,
there you go.
But it's not. No, it's not really. It's not really an acronym because it's not short. You've come up
but
with
it's something. Yeah, it's something
a
that
mnemonic
when I'm.
there.
Yeah, you can just grasp onto it, and I think it really nicely summarizes that idea of what case management is about. Because I think, in some sectors or some services, there can be case management positions alongside, say, counselling or therapeutic positions. They can be blended, so it might be that it's not a specific position, and so it's good to understand, what is the difference there. Because of course, as part of, say, if I'm in a counsellor's role, I'll, of course, you would hope, be thinking holistically about that person, and engaging with other services where appropriate. But the difference, I suppose, with case management is really thinking very clearly about those established relationships that you can bring them into the treatment, if you like, or into the room, so that it becomes a lot more seamless. That it's not that the person themselves needs to be, well, now you can go off to your appointment with whoever, and we start to break that down. And in fact, it was actually at St Vincent's that they did a trial of open dialogue, which is an approach to therapy, but also to sort of case management processes, which really brings everybody around the table with the client there. And I do remember amazing experiences where, working through thorny problems with some people, to have the person themselves accessing treatment, witness some of that conversation, be part of that conversation, can help them to understand, and to actually come forward with some of the best solutions that we hadn't even thought of. So I think it's also about that idea of letting go of this sort of expert positioning we often like to jump into, which can often trip us up, and really going back into that curiosity about what can we grow for this person, not just what can we stop or shift to one side, but what can we actually grow, and actually spend some time focused on that with these other players in the room.
Very good. All righty. So I won't lie, we haven't had anyone want to. You've obviously covered it far too thoroughly. Alternatively, everybody's too shy because they realize that you're so, you're such the model of good case management. So everyone's a bit nervous, to share their experiences, because now they're realizing they're not, the things that they perhaps could be doing that they aren't.
But Chris, what I will say is, as we're wrapping up, is anybody out there, my job, as far as I see it, at the Ministry of Health within the Centre for Alcohol and Other Drugs, is to provide support and advice. It might not always be good advice, but nonetheless, I'm a resource, as I see it, to the sector, to people on the ground, to people within the ministry. And so if people do have questions or they want to talk through something, I'm really happy to help where I can, or point them in the direction of someone who might be able to support them. So I suppose this is an opportunity for me to let everybody know that that's, as I see it, my job. I mean, there's a chief addiction medicine specialist, Dr. Deborah Zador, who is at the ministry, of course, as well. And so, and she's the expert, particularly when it comes to all things medical and related in the alcohol and other drug field. But if there are other things that people want to talk through, or ways that they think I can support them in their work, then I would encourage them to reach out.
Thanks very much, Suzie.
You're
Well, we
welcome.
might wrap it up there, but before I let you go, a big thanks to you. And to everybody listening, I hope you join me in thanking Dr. Hudson. And I'd like to just mention that next week will be a journal club for Daria. One of our registrars, Dr. Roman Pillay, will be presenting a journal. So join us next week for that. But in the meantime, thank you very much, Suzie. We'll see you all next time.
See you later.
Bye.